This video will review the basic technique of oro tracheal intubation, focusing on the fundamentals of laryngoscopy and passage of the tube into the trachea. Basic airway management, including the use of the oropharyngeal airway and bag valve mask, and surgical airway procedures such as cricothyrotomy, are covered in separate videos. Refer to the written section of this procedure for a review of the indications and contraindications of oro tracheal intubation, as well as evaluation of the difficult airway. The use of rapidly acting sedatives and neuromuscular blocking agents helps to create the best possible intubating conditions. However, their use is beyond the scope of, and thus intentionally omitted from, this video. The two main types of laryngoscope blades are the Macintosh and Miller blades. The Macintosh blade is curved and designed to have its tip placed into the vallecula. Application of gentle forward and upward pressure indirectly elevates the epiglottis and exposes the vocal cords. The Miller blade is straight and is designed to have its tip placed inferior to the epiglottis. Application of upward pressure directly lifts the epiglottis anteriorly, revealing the vocal cords. Endotracheal tubes come in a variety of sizes. Most adults will require an 8/0 tube, although size 7/0 may be required for smaller adults. Use a malleable stylet during intubation to provide shape and strength to the endotracheal tube. Place a 20 to 30 degree angle hockey stick bend just proximal to the cuff to facilitate passage of the tube into the trachea. Avoid placing an angle greater than 35 degrees in the tube, which may make intubation difficult or impossible. Prior to the intubation, assure that all equipment is in good working order and ready to use. Check the light on the tip of the laryngoscope. Temporarily inflate the balloon on the endotracheal tube to assess its integrity. Lubricate the stylet and place it into the endotracheal tube. The tip of the stylet must not protrude beyond the end of the endotracheal tube in order to avoid iatrogenic injury. Position the patient supine in the stretcher. Raise the stretcher so that the patient's head is at the level of your sternum. Remember, a difficult airway examination should be performed prior to intubation. This technique is reviewed in the written section of this chapter. Place the patient in the sniffing position with the neck flexed and the head extended. This maneuver aligns the axes of the oral cavity, the pharynx, and the larynx, and facilitates direct visualization of the glottic structures. Pre-oxygenate the patient with 100% high-flow oxygen for at least 3 to 4 minutes to prevent desaturation during the intubation. If possible, pre-oxygenate the patient without bagging in order to limit gastric insufflation and aspiration. Ensure that monitoring equipment, including blood pressure cuff, cardiac monitor, and oxygen saturation probe, are in place and properly functioning. In this patient, rapid sequence intubation was performed, with etomidate and succinylcholine injected at this point in time. The use of pharmacologic adjuncts is essential in the vast majority of endotracheal intubations, but their use is beyond the scope of this video. Instruct an assistant to perform the Selleck maneuver by applying direct posterior pressure on the cricoid cartilage. This maneuver may help prevent aspiration and should be maintained during the entire procedure until the endotracheal cuff is inflated and correct tube placement is confirmed. Assure that the patient is still in the sniffing position. Hold the laryngoscope blade with your left hand regardless of which hand is dominant. Grip the proximal portion of the handle and the back of the blade and cradle it between the pads of your fingers and thumb. Open the patient's mouth with your right hand using the scissor technique. Insert the laryngoscope on the right side of the patient's tongue and displace the tongue forward and to the left into the mandibular fossa. Advance the laryngoscope and identify the epiglottis. Correct positioning of the blade depends on whether a curved or straight blade is used. Place the tip of the curved Macintosh blade into the vallecula and lift anteriorly to expose the vocal cords. Place the tip of the straight Miller blade under the epiglottis and lift anteriorly to expose the vocal cords. Once the tip of the blade has been correctly positioned, lift the laryngoscope forward and upward. Direct the force along the axis of the laryngoscope blade toward the ceiling over the patient's feet. Avoid rotating the blade handle backward because this can damage both the teeth and structures near the blade tip and will not improve the view of the glottis. It may be helpful to have an assistant retract the patient's right cheek in order to improve visualization of the glottis. Once the vocal cords are identified, do not take your eyes off the target. Instruct another assistant to place the endotracheal tube into your right hand. Introduce the endotracheal tube into the right side of the patient's mouth and along the course of the laryngoscope blade toward the larynx. Do not insert the tube along the midline because this will obstruct your view of the glottis. Watch the tube pass through the vocal cords and into the trachea. Advance it so that the tip of the tube lays about 4 centimeters distal to the cords. Remove the stylet and inflate the endotracheal cuff with air. Use only enough air to prevent air leaks during tidal volume respiration. This usually requires less than 10 milliliters of air. Confirm tube placement by placing an end-tidal CO2 detector in line between the bag or ventilator and the endotracheal tube. Most end-tidal CO2 detectors function by changing color when exposed to exhaled carbon dioxide. Auscultate over each lung and assess for symmetrical breath sounds. Also, auscultate over the epigastrium to assess for gurgling, which indicates esophageal tube placement. If lung sounds are heard in the right lung but not the left, right main stem bronchus intubation has likely occurred, and the tube should be withdrawn until symmetrical sounds are heard. Secure the tube to the patient with tape or a prefabricated endotracheal tube holder. The method of securing the tube will depend on institutional protocol. Once the tube is secured, obtain a chest radiograph to evaluate the depth of tube insertion. The tip of the endotracheal tube should be positioned in the mid-trachea with the tip several centimeters above the carina. Finally, let's review the steps of endotracheal intubation in real time. Hold the laryngoscope in your left hand and open the patient's mouth with your right hand. Insert the blade and sweep the tongue from right to left. Carefully advance and position the laryngoscope and lift the patient's mandible forward and upward. Identify the glottis and insert the tube on the right side of the patient's mouth and into the trachea. Remove the stylet and inflate the cuff. Begin to ventilate the patient and confirm proper tube placement.